With patient assessment, a mnemonic to help you remember this would be improper physical assessment, IPPA. So again, the sequence would be inspection, palpation, percussion, and auscultation. So inspection, palpation, percussion would be tapping to produce sounds and vibration. Auscultation would be listening to sounds. And again, this sequence is applicable when you're assessing all body systems, except when we're carrying out abdominal assessment. So rather with abdominal assessment, the sequence would be to inspect, to auscultate, and then we want to percuss and then palpate. So that will help us to avoid altering vowel sounds. So again, you want to note the difference between both. So again, we said the technique used in order performed, except for abdominal assessment, would be number one would be inspection, where you visually examine. It starts with your first interaction with the patient. So you can just stand and visually inspect the skin. If you notice on this picture, you would see some skin discolorations, like your petechia and your purpura. These are usually associated with bleeding under the skin. Your petechia would be those pinpoints. So you can see those pinpoint spots on the skin. They are often red in color, while your purpura are usually those larger reddish purple blotches that you see on the skin. They do not blanch with pressure. If you press on them, they don't blanch. And again, this is usually due to bleeding underneath the skin or possible blood dyscrasias. The second sequence would be palpation. So again, you want to remember, you want to warm your hands, you want to use fingertips for fine touch, like when you are palpating pulses or nodes, you want to use fingertip. You want to use the palm of your hands or the ulnar edges, especially for vibration. And we always want to start with light palpation before we progress to deep palpation. And you want to use both hands for deep palpation or when we are trying to assess movable structures like the kidneys. So we always want to use both hands or bimanual palpation for deep palpation. And then we'll progress to percussion, which is the third sequence. Percussion is that method of tapping body parts with the fingers or hands or small instruments as part of your physical examination. So you are tapping, so you can see how they are tapping over the finger to produce sounds of vibration. Usually we do it to determine the size, consistency, or borders of body organs, or we also do it to determine the presence or absence of fluid in certain body areas. Again, percussion is performed after inspection and palpation, except for abdominal assessment. Remember, for abdominal assessment, we said you want to inspect, auscultate, percuss, and finally, you want to palpate. There are 5 types of sounds that can be elicited during percussion. So one of them would be resonance. So resonance is that hollow, low-pitched sound that is heard over an area that is filled with air, for example, the lungs. So you want to hear resonance over the lung. Is that hollow, low-pitched sound that is heard over the air-filled lungs, like a normal lungs? You want to hear, you want to percuss resonance. Hyperresonance would be that loud booming sound that is heard over abdominal over abnormal lung tissue. Usually you can see this in clients with chronic obstructive pulmonary disease. So hyperresonance would be that booming sound heard over abnormal lung tissue, like in clients that have overinflated air-filled lungs, like in COPD. Timpani is heard as a drum-like sound, usually over the bowels or over the stomach when it's filled with air. And dullness, usually we percuss dullness over solid organs like the liver and the spleen. So you percuss, you hear this soft muffled sound when you percuss over a solid organ like the liver and the spleen. And there's flatness, which is normally very soft and accessed over muscles and bones. So again, flatness will be percussed over muscles and bones. And finally, there will be auscultation. So you want to remember, you're going to use your stethoscope, and we want to use the diaphragm of the stethoscope to listen to high-pitched sounds. And when you're using the diaphragm, so this would be the diaphragm, you want to place it firmly against the skin surface to form a tight seal. So again, the diaphragm for high-pitched sounds. And so that's the diaphragm, and that's the bell. And we're going to use the bell, which is a smaller part, to listen to soft, low-pitched sounds. And when we're using the bell, we're going to place it lightly on the skin surface. So again, you want to listen over bare skin, not through clothing. And if the patient is hairy, you might want to moisten the hair, the body hair, to prevent crackling sounds from interfering with your auscultation. Again, you must know what your normal range is for our vital signs are. So again, the normal respiratory rate for a newborn would be between 30 to 60. For an adult, it will be between 12 to 20 per minute. So again, you can still come back to this slide, pause the video, and go through what these ranges are. So the normal pulse rate will be between 120 to 140 for a newborn. If the newborn is crying, it can go up to 180. For an adult, it should be between 60 to 100. Remember, if it's less than 60, we say that patient is bradycardic. If it's more than 100, we say that patient is tachycardic. And the normal blood pressure should be less than 120 over 80. In the newborn, it should be between 65 over 41 millimeters of mercury. With normal temperature, the rectal temperature should be at about 99.6 degrees. The oral temperature should be less at 98.6, while the axillary temperature should be between 97.6. So you can see they are just 1 degree less than the other. So again, you always want to remember in the infant population, if we have a rectal temperature that's less than 36 in a young infant, so we can say the patient is hypothermic, that may be a sign of sepsis. So again, hypothermia in a young infant could be a sign of sepsis. Again, what are factors that can influence our body temperature reading? If your client is elderly, a faulty thermometer, dehydration, environmental temperature, even infections, all of these can affect the normal body temperature reading. Let's look at, as part of our physical assessment, when we assess breathing patterns. So again, in the adults, we know that their breathing is usually coastal, meaning the chest moves, it's regular. We know expiration is slower than inspiration, and the rate is between 12 to 20 respirations per minute. But in the neonates, we know they are diaphragmatic breathers, meaning the abdomen moves when they breathe. Their breathings are usually irregular. It's between 30 to 60 respirations per minute. Again, we talked about abdominal respiration. So usually with abdominal respiration, breathing is accomplished by abdominal muscles and use of the diaphragm. So most times you might notice your client is having abdominal respiration. This could be used to increase effectiveness of ventilatory process in certain conditions. Again, you must know what apnea means, which is a temporary cessation of breathing. Your client could also be dyspneic, which would be difficult or labored or painful breathing. Most times it could be considered normal at certain times. For example, after extreme physical exertion, dyspnea would be expected. You could also see hyperapnea. So this would be an abnormally deep breathing, or autopnea or platypnea. So again, this would be autopnea, which is that inability to breathe except when the trunk is in an upright position. So that would be autopnea. So the patient will have discomfort when breathing while they are lying down. And it's common in people with some types of heart or lung conditions. Again, we also have platypnea, where the patient would have shortness of breath on sitting up is relieved when the patient lies down. So it's actually the opposite of orthopnea. So again, the patient is sitting up and they're having difficulty of breathing. When they lie down, they feel a lot better. That would be platypnea. And then we also need to know what hyperventilation means. So that would be that abnormally rapid, deep, and prolonged breathing. So you hyperventilate by exhaling more than you inhale. So that's going to be hyperventilation when you exhale more than you inhale. And it's usually caused by central nervous system disorders or drugs that increase sensitivity of the respiratory center or even acute anxiety. So what happens with hyperventilation? It's going to produce respiratory alkalosis because there's a reduction in CO2 because you are exhaling more, so you are pushing out all of your CO2. So it's going to lead to respiratory alkalosis. With hypoventilation, there is reduced ventilatory efficiency. So this time around, what's going to happen? It's going to produce respiratory acidosis. It's going to produce respiratory acidosis because there's going to be elevation in the patient's CO2 level. So if a person hypoventilates, the body's carbon dioxide level rises. So it's going to cause a buildup of acid and too little oxygen in the blood. So with Kussmaul's respiration, or what we refer to as air hunger, you're going to notice this abnormal, deep, rapid, labored breathing that occurs as an involuntary response to severe acidosis. Where do you see patients with this abnormal, deep, rapid, labored breathing? Like maybe clients with diabetes, clients with kidney failure. So you can see Kussmaul's respiration in clients with diabetic ketoacidosis or clients with kidney failure. With Cheyne-Stokes respiration, you would notice alternating cessation of breathing or apnea and hyperventilation. With paradoxical respiration, breathing pattern is, so you see a breathing pattern in which the lung deflates during inspiration. So it's almost like an opposite of what it should be. So here, the lung is deflating during inspiration and possibly due to a flail segment or a flail chest. So it's acting opposite to normal. And with Biot's respiration, here you see a group of regular deep inspirations that are followed by regular or irregular periods of a cessation or that temporary cessation of breathing. So that will be your Biot's respiration. Again, as you assess your patient might be cyanotic. Cyan means blue. So the skin is going to appear blue, just like we see in this patient. So the skin is going to appear blue. And that bluish discoloration is because of the client is accumulating excessively unoxygenated hemoglobin in the blood. So you see this excessive accumulation of unoxygenated hemoglobin in the blood. But again, you want to make a distinct differentiation between cyanosis and acryocyanosis. So if we see cyanosis on the hands and feet and around the lips in a newborn infant, it's a normal finding in babies. That would be acryocyanosis. But if we have central cyanosis, such as cyanosis on the lips, on the tongue, on the head, or torso, that's central cyanosis. That needs to be reported to the healthcare provider. Again, when we assess our patient, you are looking out for stridor. Stridor would be that harsh, high-pitched sound, and it's usually associated with airway obstruction happening around the larynx. So again, stridor would be that harsh, high-pitched sound. Again, we said it's associated with airway obstruction near the larynx. So again, inspiratory stridor suggests a laryngeal obstruction. because this obstruction, you're trying to inspire to take in air, and there's an obstruction. That's what we refer to as inspiratory stridor. You notice this high-pitched harsh sound when the patient tries to inspire, while expiratory stridor can also imply a bronchial obstruction. So there's an obstruction to air trying to leave the lungs through the bronchus. So again, you want to take note of that high-pitched sound. That tells me my patient has stridor. With the blood pressure, you always want to check both arms and compare results. A difference of between 5 to 10 millimeters of mercury is normal. With the pulse pressure, what's your pulse pressure again? Is the difference between the systolic and the diastolic blood pressure. Normal should be between 30 to 40 millimeters of mercury. Your pulse pressure represents the force that the heart generates each time it contracts. So again, your normal blood pressure should be between 120/80. So what's our pulse pressure? We said it's the difference between the systolic, which is 120, and the diastolic, which is 80. So that patient's pulse pressure would be 40 millimeters of mercury. So if we have a high pulse pressure, it means that the patient's heart is working harder than it should. It means that the arteries are not as flexible as they should, or as they should be. So either of these two increases your client's risk for a heart problem or circulatory problem, maybe a heart attack or a stroke. We also need to assess our patient for orthostatic high blood pressure, orthostatic blood pressure. So again, the orthostatic vital signs may be indicated to evaluate patients who are at risk for hypovolemia, maybe your patient who is vomiting, who has diarrhea, who is bleeding, or might need to evaluate orthostatic vital signs for patients who have had syncope or near syncope. Maybe they are dizzy or they are fainting, or maybe they are at risk for a fall. So any significant change in vital signs with a change in position signals an increased risk for fall. So again, any significant change in vital signs, whenever your patient changes position, so he's standing, we check his blood pressure, he's sitting, we check his blood pressure, and if there's a difference, then that patient is at risk for a fall. How do you even take orthostatic blood pressure? You want to have the patient lie down for 5 minutes, and then you measure the blood pressure and the pulse rate, and then you have the patient stand up, repeat the blood pressure and the pulse rate measurements after standing, 1 and 3 minutes apart. Again, remember when you're taking the blood pressure, you want to make sure you cover 50% of the limb from the shoulder to the olecranon with the cuff. You want to cover at least 50% of the limb from the shoulder to the olecranon. And if your cuff is too narrow, it's going to give you an abnormally high reading. If the cuff is too wide, it's going to give us an abnormally low reading. As we assess the skin, we want to check for pallor on the buccal mucosa or the conjunctiva. We want to check for cyanosis on the nail bed or the oral mucosa. We want to look at the sclera to assess for jaundice. Again, look out for edema on the skin. Look at the eyes. Look at the sacrum. Remember, in patients with fluid overload, if they've been lying down for an extended period, what happens? The fluid begins to migrate from the legs to the sacral region. So it's very important that you assess this area for edema. We also need to check for turgor. So how do you check for turgor? You want to pinch the skin, and it should remain tented for 3 seconds or less. That's normal. If it stays tented for more than that, then that's an abnormal finding. Remember, in the elderly, you want to check for turgor over the sternum. So for the elderly, this is where we're going to assess for skin turgor over the sternum. With the nails, please look at the shape of the nails. Look at the contour. Look out for clubbing. The nails can give you signs of prolonged decreased oxygenation. Look at the texture of the nail. Look at the thickness. So that's part of your assessment with this patient. Again, assess for capillary refill. Press on the nail bed and assess for the capillary refill. The normal should be less than 3 seconds or less, and it should return to the normal color. So that's part of your assessment. With assessment of the eyes, we want to start with looking at the visual fields of peripheral vision. So that's vision as it occurs outside the point of fixation. So again, you're looking at vision to the side. If we look at this image, the first image, you can see this patient has floaters. See all these things floating around the eyes, or they can even tell you they feel like a curtain is appearing in their vision, or there's a sudden onset of light flashes or cloudy vision. That would tell us this patient might probably be having retinal detachment. So again, this patient may describe a shadow or a curtain coming down over their vision. So usually we see this with retinal detachment. With this other image, you can see how there's a gradual loss of central vision. Whatever is happening here, this window on this area, this patient is not seeing it again. So you see a gradual loss of central vision, but the peripheral vision, the vision to the sides are still intact. Again, this would be a patient with an age-related macular degeneration. Whereas with this patient's eyes, you can see they still have their central vision intact and there's loss of peripheral vision. So there's a gradual loss of peripheral vision, or what we refer to as tunnel vision or normal central vision. These patients would also complain of increased sensitivity to glare and halos around bright light. So you'll see this kind of assessment findings in patients with primary open angle glaucoma. And number 4, you could see the image kind of looks blurred. So the patient might complain of painless, gradual loss of visual acuity with blurry vision. They will complain of glare and halos around light. There will be decreased color perception. So these patient findings indicate that our patient might have a cataract. So with cataract, there will be a painless, gradual loss of visual acuity with blurred vision. They will also complain of glare and halos around light. They will complain of decreased color perception. The next we'll look at will be visual acuity. So visual acuity measures the ability of the eye to distinguish shapes and the details of objects at a given distance. So usually we use the Snelling's chart to assess for visual acuity, and the normal should be 20/20. When you're assessing the pupils, we use this acronym PELA. Pupils equal, round, reactive to light, and accommodation. So that's an acronym that is used to document a common pupillary response test. So you want to see the pupils equal, they should be round, they should be reactive to light, and accommodation. So if we notice a pupil that is fixed and dilated, especially one-sided or unilateral fixed dilated pupil, that suggests there's injury or compression of the third cranial nerve and possible upper brain stem. If we notice a patient who is comatose and has fixed and dilated pupils, that tells us this patient has a poor prognosis, especially if the pupils are dilated and fixed on both eyes. We also need to assess for ptosis. So that will be drooping of the upper eyelid. So if I see drooping of upper eyelid in my client, it could be as a result of a tumor around the eye or behind the eye. It could be as a result of diabetes or myasthenia gravis or even a stroke. You want to assess for photophobia, which would be that intolerance to light, maybe as a result of a migraine. You want to assess for nystagmus, which would be that abnormal, involuntary, rapid eye movement, maybe as a result of a stroke or multiple sclerosis or even trauma. We also need to assess for strabismus, which would be that involuntary drifting of one eye out of alignment with the other eye. We also need to assess for corneal reflex. So you get a cutting maybe a cotton wool and try to elicit a blink reflex or an eyelid reflex. So that's involuntary blinking of the eyes when you try to stimulate the cornea by touching it with a foreign body or something. So absence of a corneal reflex may indicate a stroke or a deep coma. You also want to assess for red reflex. So with red reflex, this is what the eyes should be, what they should look like. So you may notice this is usually common in pictures, that when you use a flashlight to take a picture, you would notice a glow of the pupil. So usually it should be this way. But if we have it, if the patient has this instead, so they have a white glow of the pupil instead of the usual red reflex, then you want to start suspecting retinoblastoma, especially if it's a child, because that's the most common childhood intraocular malignancy. So instead of the usual red reflex, we'll see this light reflecting off of the tumor, and that's what is going to cause the pupil to appear white. Again, an absent red reflex can result from maybe a cataract or a vitreous hemorrhage or even a corneal scar. We also need to elicit corneal light reflex. So the corneal light reflex refers to how light is reflected from the corneas of the eye. So if the eyes are in proper alignment, a light reflection appears equally centered on both pupils. If it's unequal, an eye misalignment disorder, maybe a strabismus or amblyopia, may be present. Again, when you assess the ear, you need to remember for the adult, the U tells me up. So we want to pull the pinna, pull the ear back and up for patient assessment if it's an adult. For a child, the D tells me down. So you want to pull the ear back and down for any child under 3 years. With the tympanic membrane, if we use our otoscope, you would notice that there will be a light reflection, this cone-shaped light reflection. Usually, you will see this at the 4 o'clock or 5 o'clock position in the right tympanic membrane, while on the left tympanic membrane, we'll see it at the 7 or 8 o'clock position. When we assess the ears also, we might want to carry out a Weber's test. So the Weber's test is a screening test for hearing performed with a tuning fork. So again, when you assess for sensorineural hearing loss, I'm going to assume I have my nerves going to the ear from the tuning fork. So if there's an obstruction here, what it means is that the nerve going to this right ear is damaged. When I strike my tuning fork, the patient is going to hear the sound very well on the left ear. So that would tell me that is a sensorineural hearing loss. But if it's a conductive hearing loss, so with a conductive hearing loss, so let's say this is our track where the sound wave is supposed to be conducted to the ear. So if there's an obstruction here, what is going to happen is that the sound is going to be piling up on the area that has the problem, and almost like traffic building up, cars building up in traffic, and all of them are going to be honking their horns. All of them are going to be honking their horns, and it's going to cause the patient to have an increased sound in the ear with a problem where there's that obstruction. So that would tell me this is a conductive hearing loss. So with a sensorineural loss, the sound will be heard better in the opposite ear, in the good ear. While with a conductive loss, the sound will be heard more in the bad ear or the same ear. With the thorax and the lungs, when we assess the thorax and the lungs, we are looking at the anterior posterior to transverse diameter of the lungs. So again, if the anterior posterior diameter equals the transverse diameter, that results in a barrel chest. Usually you see this in emphysema because of hyperinflation of the lungs. Again, you also want to look at the trachea. If there any tracheal deviation, is there any mediastinal shift that could indicate a tension pneumothorax? We also want to elicit tactile fremitus. So with tactile fremitus, is that palpable vibration of the chest wall that results from the transmission of sound vibrations through the lung tissue to the chest wall. So again, an increase in tactile fremitus indicates maybe a denser or inflamed lung tissue, which can be caused by diseases such as pneumonia, or a decrease suggests air or fluid in the pleural space, or a decrease in lung tissue density, which could be caused by maybe COPD or asthma. Again, you want to assess for respiratory excursion, which is the degree to which the rib cage expands and contracts as a person breathes.